Good morning, all of you. And this is the webinar, which is about the cervical rehabilitation progression. We have been trained and asked which muscles is weak or which joint is restricted. But this traditional approach often misses the bigger picture. From the movement map philosophy, the challenge us to shift our question entirely. Instead of hunting for a single faulty structure, we ask how is the body organizing the movement? And this fundamental paradigm shift to recognize that cervical spine is rarely a local tissue problem. The body operates as an interconnected movement network, and pain represents a breakdown in how that network absorbs and expresses the force. Whenever we ask the person to do a specific exercise, he does the exercise very efficiently and effectively. Sometimes he finds some compensation during the cervical spine flexion as well as extension. So, from which perspective we should go step by step manner. A patient may present with neck pain, but the true dysfunction could be the thoracic stiffness. So we open up a more effective treatment pathway that address the root cause, not just the symptoms location. Cervical spine is a critical hub for the kinetic chain. The traditional paradigm shift and the movement map. In traditional, as I told you, which muscles is weak or which joint is restricted. But in movement map, we just understand how this body is going to move, how we have to organize a specific motion, where the cervical spine begins, the compensation, where the movement fails, all these things that we should understand. If the lumbar spine has a stenosis, the cervical spine has to pay the price also in terms of hypomobility. So it is not always cervical spine uh, get injured in isolation. There are some compensation like thoracic stiffness, lumbar spine, hypomobility, hip extension deficit, a lot many things. So let me share some clinical observation that has transferred my practice. So when I see the cervical pain combined with thoracic hypomobility, I have learned to address the thoracic spine first, and the results are remarkable. Similarly, when neck dysfunction presents alongside the poor scapula control, that treats the shoulder complex, which often resolves the cervical complaint more effectively than the direct neck treatment. So, when your patient complains of neck pain, start addressing the scapula first, make the scapula position stable in its original position or anatomical position, and ask the person to move his neck. If he moves his neck very efficiently and effectively, then the problem is from the shoulder point of view. Perhaps most importantly, when I observe the fear of movement and guarding behavior, I recognize that I must treat the brain first, not just the tissue. The cervical spine doesn't operate in isolation. It is a critical kinetic hub that sits at the intersection of multiple movement systems. The cervical spine receives the signal from the feet, ankle, knee, and hip joint, as well as the pelvis. The cervical spine must coordinate with the thoracic spine as well as the shoulder girdle. So now you understand that if any one of the joint gets restricted, how the cervical spine produces sound. This understanding has profound treatment implications. So we cannot effectively rehabilitate the neck without considering the entire movement chain. Every patient has a unique story of his movement. Every person does the different job. Our job is to read that story through the lens of whole body movement organization. So for that, these are the five map assessment framework. This framework represents my comprehensive approach to understanding cervical dysfunction. Let me walk you through the each component. Motion. I observe the global movement expression, looking for fluidity and symmetry. Is the patient moving freely or with restriction? Then I assess the multiplanar control across the sagittal, frontal, as well as the transverse plane. Can the patient control the movement in all the direction? After assessing the control, then I move to the evaluate the energy transfer, the chain from foot and ankle through the knee, hip, and the pelvis up to the thoracic hub. And finally, to the cervical orientation center. This is where we often find the missing link in the rehabilitation. Fourth, the adaptation. I test the neuromuscular responsiveness and load acceptance. And once you have assessed the adaptation, you should check the perception also. You have to assess all these five framework that helps you to understand how you should assess the cervical spine. And from the perception, the movement confidence and the pain expectation. This is very crucial because what the patient believes about their movement directly impact their recovery also. Sometimes you must have noticed in your patient when you ask them to go for the cervical spine flexion, he is into the catastrophizing phase. The person has a fear of producing a movement of flexion as well as extension because he was in tremendous pain yesterday. So this five dimension framework gives you the complete picture of cervical function that no single test can provide. There are multiple tests is available, but through these five framework, you will understand exactly where the person has a pain. The mechanical capacity assessment. The how we quantify the mechanical capacity using our 0 to 4 point scoring system with a maximum score of 40 from the movement map. We assess the seven key component, the load acceptance, controlling the descent, which evaluate the eccentric control during the lowering the movement from flexion to extension. If you look closely in your patient when he goes for the flexion to extension or the extension to flexion, there might be some deviation of a neck that you should consider it as a somehow there somehow some compensation is going on. There might be some sensory issue also. The rotational capacity, which looks at the segmental rotation ability, which is essential for functional movement like checking the blind spot while driving. The direction change, reorientation, and the stability. Reach control, dynamic stability during the reaching activity. Like when the person is about to reach